Hello, and welcome to today's first Essential Together Huddle, focusing on supporting staff and the safe reintegration of essential care partners. Please note that this session is being recorded. I'm Carol Fancott. I'm the Director of Patient Partnerships and Engagement here at Healthcare Excellence Canada, and I'm pleased to be your host today. We are also pleased to be able to offer this webinar with simultaneous interpretation. If you would like to hear the voice of our interpreter today, please select French from the interpretation menu at the bottom of your screen. These huddles are an opportunity for us to hear and to learn from others working to safely reintegrate caregivers as essential care partners, those who may be working in other settings from your own and and who may have different perspectives based on the roles that they play. As well, this is an opportunity to share what you've experienced, developed, implemented, or led in this regard. And we hope that we're able to create a safe space where everyone can share and learn together. We invite you to use either official language to share your questions, ideas, and comments in the chat throughout today's session. I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation, and we recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. If you have not yet done so, we invite you to please respond to the two poll questions at the bottom of your screen. Please scroll down to see the second question that is in both English and French, and be sure to click submit to send the responses to us. And as I introduce our guest speaker, I would ask that you please take a moment and to introduce yourselves in the chat. So joining us today, we have Jennifer Cornell, and she is the Director of Long-Term Care with the County of Grey in Ontario, responsible for 3 long-term care communities. She's a respected long-term care and health system leader with over 20 years of progressively senior leadership roles. Jennifer is a servant leader focused on quality care and service initiatives, team development and growth. And she's harnessed the County of Grey Color It Your Way philosophy, and she's engaged 316 residents and over 500 team members in a resident-centered care approach. Jennifer's passion to create a program that would address the concerns related to social isolation during the pandemic became a mission for her. And through this collaborative work, Jennifer led Grey County's care communities in the development of the Designated Care Partner Program. We also have our great producers, Gina Peck, Sheena Powell, and Kelly Ripley, who are operating behind the scenes today. So welcome to all of you, and a special welcome to patients, residents, families, caregivers, and essential care partners who have joined us. So we are going to move on our slides and take a look at Healthcare Excellence Canada. We are a newly amalgamated organization that has brought together the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement. And we have a relentless focus on improving healthcare with and for everyone in Canada. Next slide, please. And so in today's session, I'm going to provide you a brief overview of the Essential Together program, and then you're going to hear from Jennifer about how her organization in Grey County have supported staff through education to safely reintegrate essential care partners back into their facilities. And our goal through this huddle is really to share with each other what is happening across Canada and how we are safely welcoming back essential care partners. Throughout this presentation, please use the chat box to share your thoughts, comments, and questions. So next slide. So what is Essential Together? And on to the next slide, please. It's a program that was developed to support the safe reintegration of essential care partners into health and care settings during this time of pandemic and beyond. And the program focuses on 3 particular audiences: those of policymakers, those who implement policy, and those who are impacted by policies. And so again, the focus of these national huddles is very much concentrates on the actions to implement the policy guidance. The next slide, thank you. And at its core, this program is about recognizing the value that essential care partners bring to the healthcare system and to the care of their loved ones, and differentiating essential care partners from that of visitors. And so here you'll see how we have made that distinction between the roles. And fundamentally, the use of the language of essential care partners helps us to recognize this essential role, but also to note that the language is different across the country, where you'll hear Jennifer talk about designated care partners. We've also heard essential caregivers or essential visitors as well. But really, the key elements of an essential care partner is that they're identified and that they're designated by the patient, the resident, or the client, and they may be a family member, a close friend, or another caregiver that is deemed important by the patient, resident, or client to participate and to help advocate for their care. And they provide support in many ways: psychological, physical, and emotional support. Next slide. And so how can we safely reintegrate essential care partners? We hosted a policy lab in the summer that brought together a range of stakeholders, policymakers, those that implement policy, and those that are impacted by this policy. And what we did, and you will see on the next slide, is we were able to create what is the ideal journey for caregivers as they are coming into facilities. And it was through this ideal journey that we were then be able to co-develop the policy guidance, which you'll see on the next slide. The policy guidance focuses on two main areas: that of the identification and preparation of essential care partners, and the second being the entry into the facility. And there are 7 components, as you can see, of this policy guidance. And today, Jennifer will be speaking to establishing staff education to understand roles and safety protocols for essential care partners. In the coming weeks, the national huddles will focus on different elements of this policy guidance. So next slide. At the core of the policy guidance are the 3 foundational principles, as we've talked about: recognizing the value of essential care partners, being able to differentiate then their role of essential care partner from that of visitor, and that engagement needs to be throughout the process of developing and putting into practice policies and the guidelines. Next slide, please. So as a program, we want organizations to commit to a call to action that will safely welcome back essential care partners. There's an Essential Together tool that is there to support the reflection of these 7 elements and to help organizations. We also have learning bundles and curated resources and tools to support in each of those elements of the policy guidance. And then we are hosting peer learning opportunities like these national huddles to bring us together and to talk about the different ways and strategies that people have been using across the country to ensure the safe re-entry and integration of essential care partners. We also offer coaching for those that would like to register with us to offer more intensive support in helping you to implement elements of the policy guidance. So that gives you some context for the Essential Together program and what to expect in upcoming huddles. And I'm just going to take a look at the poll results that have come in. Thanks to all that have participated. And so we're seeing participants that are coming across a range of settings: long-term care, hospitals, congregate care, as well as outpatient care settings. And many of you have also identified other as your care settings. So please tell us more by using the chat box. And there's a mix of people and organizations that have achieved, are in progress, and some that have not yet started on this work. Thanks to all who have answered our poll. So I'm now going to pass it over to Jennifer to walk us through the work that's been happening in Grey County. Thanks, Jennifer, and over to you.
Great. Thanks so much, Carol. Thank you for that great introduction. And I'm so honored to be here to share our story. And I hope that everyone on the call, and I see that there's people from all across Canada, which is really exciting. I hope that you find it interesting and helpful. So next slide, please. As Carol mentioned, Grey County is a rural municipality in Southern Ontario. We operate 3 care communities, and they're listed here, and they range in various sizes. And we believe in a resident-centered care approach, and our promise in Grey County long-term care is to color it your way. Those are our words for resident-centered care. Next slide. In Ontario, March 13th was the date that all visitors were restricted from entering into long-term care. It did not take long for the impacts of that change to be recognized in our residents. Unfortunately, it was still several months before we were able to implement plans to safely support caregivers at the bedside. We quickly, as I know all of you were doing the same thing, supported virtual visiting, window visiting, and by early summer, were able to support scheduled indoor and outdoor visiting stations. Despite this, team members, those are our words for staff, we go back and forth, but team members were noticing and talking about how the isolation was impacting the residents that they provide care for. They were noticing residents weren't eating as well, were losing weight, they were more tired and lethargic, and in some cases, they were noticing a decrease in their abilities and in some, a rapid advancement of their diseases. So we were all working so hard to protect our residents from COVID-19. And at the same time, we're seeing that those strategies were also impacting overall wellness. We started talking about how to safely allow caregivers back into the home. We looked around to see how others were handling this challenge and found the work of Hotel Dieu Grace in Windsor. It's a chronic care hospital who had started a pilot for essential caregivers. I reached out, and Hotel Dieu was very willing to meet with us via Zoom. They answered all of our questions and graciously shared their policies and procedures. And we used their program as a template to create a long-term care specific approach. Next slide. And so with a good foundation to start from, we began the work of engagement, making sure to talk to and get feedback and direction from all of the stakeholders. So we reached out to all team members in all of the different departments, making sure to talk to the medical director, families, residents, the councils, as well as staff, as I mentioned. And so once we had a draft policy put together, we also looked externally to our partners in public health to make sure that they were supportive of the approach that we were taking. Next slide. We wanted to start the conversation with staff in our daily huddles. The teams huddle every shift to come together to plan and prepare for the shift ahead. We talked about what the role of the DCPs, designated care partners, would play and what would the role of the staff be. Family and friends had always been a part of the fabric of long-term care, and this was an opportunity for us to really formally acknowledge their contribution and to recognize family, friend, caregivers as a part of the care team. And this was something that we have not really formally acknowledged in long-term care. Next slide. We created a discussion guide to support the conversation at the huddles. We started with the leaders in each home, talking about how to engage conversation, what kind of questions should we be asking, what did we need to talk about to sort out how we move forward. So the leaders took these questions to the huddles and went through them. It didn't take long, 10, 15 minutes, depending on the day and the concerns. And it was important that we go through all of the questions with our staff. I think one of the most important questions on this list is, what are your concerns or worries? What are the barriers? What is it that has you concerned? Next slide. And so what did we learn? We learned from the huddles that there were 2 main themes of concern. One was around safety, and the other was around clarity of role. Staff, understandably, had concerns about the numbers of people coming into the home. How would we train designated care partners? How would we manage the volume of people? How would we follow all of the rules of public health, distancing, PPE, hand hygiene, all of those kinds of things that escalated into testing even? And how would this impact the job of the staff? I heard some concerns about worries about using caregivers to change our recruitment strategies. Were we hoping to use caregivers to replace staff? And so it's important to understand and hear what these concerns are so that we can address them directly. We needed to hear this feedback and be able to provide clear, transparent information to improve the understanding of the program. We partnered with our our web-based education platform, Surge Learning, and our designated care partners actively participated in the same training modules that the staff participated in for infection control, PPE, donning and doffing, hand hygiene, etc. We also collaborated with the IPAC teams in the homes to provide training for the screeners to help designated care partners face-to-face, answering their questions, supporting them practicing donning and doffing their PPE, helping answer any questions that might come up at the moment when they arrive at the door. Next slide. Regarding role clarity, we talked about what staff noticed residents were missing by not having their family members or visitors in to support them. This made it much easier for staff to see designated care partners as helpful and supportive rather than an additional work or impacting their job in a negative way. We really were intentional with our language to support caregivers as essential, part of the care team, trained, aware of the expectations. Next slide. And so we used all the feedback that we got from the conversations we had with staff and family members and residents to develop our tools and resources. In part, they were modeled after the Hotel de Grace program, and also were modeled in response to what we heard as the barriers and the concerns. We wanted to be transparent and clear, so the roles and responsibilities of the DCP are clearly outlined. We created posters for designated care partners, for staff and residents, and we developed a visitor definition chart to help everyone keep straight the changing provincial and public health guidelines. I remember saying at one point, I would never have guessed that visiting could become so complicated and such a complex part of what we do. Next slide, please. It became really clear early on in this initiative that this project wasn't just about safe visiting during a pandemic, that it was in fact the beginning of a culture shift, a formal acknowledgement of the vital care and support family members and caregivers provide as part of the care team. We had the opportunity to create a collaborative group of leaders from across Ontario doing similar work. Participants from Hotel Dieu, from Briere, from People Care. And we're a self-declared group of nerds that meet twice a month to collaborate, brainstorm, and problem solve quality improvement and evaluation. And as part of this program, we sent out surveys after 3 months to hear what people had to say. And so here are some of the highlights on this screen. We wanted to give team members an opportunity to share their comments and concerns, identify areas for improvement, and recognize some success stories. And the responses are as we hoped. They confirmed what we believed to be true, and that care partners are essential and a valued part of the team. So overall, people were very happy with the program itself. People felt confident that there was a good supply of PPE. And this was a really important question. Do you feel DCPs are adequately trained? And while it's a high percentage of response said yes, it did identify that there was an area for some improvement. Next slide. The anecdotal responses from team members are just so heartwarming. And as we were rolling this, it started as a pilot, and then in Ontario, the visiting guidelines came out shortly after we had introduced this as a pilot, and it quickly moved from being a pilot to a program. And I used to comment in discussions and meetings that if we were fueled by gratitude alone, the designated care partner program would be all that we needed to get us through the pandemic. And there's some excellent comments that came from the surveys, really identifying how staff could see that essential care partners, designated care partners, really have a positive impact on the mental health and cognitive needs of the residents. Did you feel that did you face any barriers was an important question to help us know how might we adapt the program, what might we need to do to provide staff some additional support. And this was one that we hadn't anticipated. The staff said they don't always know who the POA is. So how do we know who to give health information to? How do we know who to tell and who's on that list? And so we needed to make some adaptations and provide some training on how to support that. And then the comment that also needs to be highlighted is some challenges regarding rules about visiting and wearing the PPE appropriately. What do we do when DCPs aren't following the rules? Next slide. When we ask for feedback, we need to be prepared to hear it and to use it to make changes and revisions and improvements. And here are just a couple of other points to highlight. Again, the benefit of reaching out and engaging with staff and finding out what they have to say. Next slide. So what are the lessons learned? What are the takeaways that, if I could choose a few specifically around staff engagement, that I would like to share with the caller, with everyone here working together on this initiative, is that it's really key to have a lead or a champion in each site. Someone to help troubleshoot, answer questions, provide support to the DCPs and the team members. And we have also greatly benefited from the work of a volunteer. We had a local volunteer reach out and say they really wanted to help with this challenge that she was seeing. She was hearing about it in the media and from her friends around the social isolation and the challenges around visiting, and what could she do to provide support. And so Linda has provided support specifically to the DCPs as they work their way through the program. I mentioned that the DCPs did their training on a web-based program, and with that comes some technical challenges, and that was one of the areas that Linda provided support to the DCPs. Communication, the words that we use really matter. Leaders need to agree on the key messages and use those words. So we used phrases and words like caregivers are vital members of the care team. They are essential, they are valued. And when we talked about some of the risks of reintroducing visitors back into the home, one of them is that in Ontario, with one positive COVID test in either a volunteer, a staff, or a resident, an outbreak is declared. And so we talked about that right up front, that if a DCP tests positive for COVID, that we are going to respond in exactly the same way as we would if a staff member or a resident, and there's no shame and blame. It's that we know that going in, and let's talk about what that actually looks like. A risk assessment tool, we identified early on that we needed a way to handle the one-off special requests. I want to be a DCP and I work in a congregate setting somewhere else. So we've drafted a risk assessment tool to help work through what some of the risks are and how we might mitigate those risks. We are hoping to be able to share that more broadly. We're still in the kind of development and practicing stage of the risk assessment tool. And finally, compliance process. The previous slide highlighted a comment of concern about DCPs sometimes not following the rules. We heard from staff in huddles and through the survey that having to police the DCPs was uncomfortable and awkward. And so we spent some time talking about the process. What do they do if a DCP isn't following the IPAC rules? Who do they talk to? How do they support the DCP? We talked about this with staff, and I talked about this with DCPs on our virtual town halls, all in a spirit of transparency. Next slide. And so how is it going? We have 318 active designated care partners safely coming in and out of the home, that's across all 3 homes. 190 of those DCPs completed their training online, and 128 of them completed their training using a course booklet. And so we needed to be prepared for DCPs who have challenges with technology, either that they don't have the technology in their home, or broadband challenges, or they just prefer to do the training through a course booklet. A large population, a large percentage of the DCPs, the team members, and our residents have been vaccinated. All of our residents have been vaccinated with both vaccines, both shots, and our DCPs and team members have had their first. And in Ontario, we are required to do rapid antigen testing, surveillance testing. And now that it's rapid antigen testing, that's three tests a week. And so we are offering and providing 600 rapid antigen tests weekly to support DCP visiting. And so we had team members saying, we're concerned about our DCPs heading to an assessment center to have their test. This was before rapid antigen testing. And so we found a way, with staff members' participation and support, to offer testing on site. And that has been a really successful and really helpful program to support DCPs. Next slide. And so what's next? How do we color it into tomorrow? We don't have the answers to these questions, but we've already started talking about it and looking at how we integrate the lessons learned and the value of the DCP program into post-pandemic care. For example, how might we involve and include the DCP as part of the move-in process, really formalizing it? Can we add the DCP to a standing agenda item at resident care conferences? So I'm really interested in hearing from my peers on this call and my colleagues across the health sector on how caregiver presence and caregiver support has become embedded in more processes. And that's something that we're going to engage the DCPs and the staff to say, what's next? How do we move from a program to support safe visiting into something that just becomes a part of our culture? Next slide. And these are just a couple of heartwarming testimonials where leaders really were able to identify the difference and the value of this program. And we can flip to the next slide. And that concludes my presentation, and I'm happy to take any questions if there are any, or have some discussion about what's possible, what others are doing.
That was wonderful, Jennifer, and just comprehensive and so clear in the work that you have done, and something that you didn't do on your own, which we love to hear about how you have engaged not only staff, but the designated care partners, and being able to create this very comprehensive way of moving forward. So at this point, we certainly welcome questions. This is an opportunity, and I do see that there's some that's already populated in the chat. And that we hope that you'll feel comfortable sharing what you may be struggling with, so that others on the call may also be able to offer their help and suggestions. As Jennifer noted, it seems like she has this great network of peer support around her that they're able to bounce ideas off of, and that's certainly what we're hoping to generate here. So maybe I'll go into the chat box. There is a question I see from Anne O'Riordan. Hi, Anne, thanks for joining us. And she is asking here, Did the designated care partners have any specific recommendations for improvement during and or after the pandemic restrictions are lifted?
Oh, well, that's a great question, Anne, and thanks so much. We haven't started engaging the DCPs quite yet in the post-pandemic discussion. It's just something we've started talking about. The intention is to share back the survey results with the DCPs to say, this is what we heard. And we've actually are just about to release the survey again we have 89 new DCPs in the last 4 months. And so they haven't responded yet to a survey. But with regards to their specific feedback as we went through the implementation of the program, the one that comes right to mind was, what do they do in the practice of a fire code? So we practice our fire drills 3 times a month. And I guess a DCP was there when we were practicing and they didn't know what to do. And so we appreciated their feedback and we were able to integrate that training as part of the DCP training. So there's actually some training on our Surge Learning and in our booklet about what do you do when you hear a code red called and the fire alarm's ringing, and what do you do if you hear a code white, and so on and so forth. So that's the kind of feedback that was really helpful in making sure we were giving people the information that they needed.
Thanks, Jennifer. I'm going to move along in the chat box here. Lots coming in. So from Jessica, this is an excellent, very informative presentation. Thanks for sharing. And that's coming from Brockville, Ontario. Now, Hope has asked, are the training materials, online training, course booklet available to the group? This would be a great resource and great presentation.
Oh, well, thanks so much. Absolutely happy to share the resources. We really benefited from peers who were willing to share and willing to pick up the Zoom or the phone and help answer our questions. I found out about the Hotel Dieu program on Twitter, so never underestimate the value of sharing your success stories and your programs on social media. And I reached out through Twitter, and Jan Keffer was really happy and quickly responded. So absolutely happy to share anything that's helpful.
Thank you for that, Jennifer. So moving down to Sarah's question now. How do you monitor designated care partners, and what happens if someone is not adhering to PPE or physical distancing or other safety protocols that might be put in place?
Yeah, so we do try to take an approach that everyone that is coming into the home, whether they're staff members or DCPs or support contract providers, are all coming in with the best of intentions. They all want to do the right thing, and they absolutely don't want to bring COVID or any other infectious diseases into our home. So we start with that understanding that we're all there for the right reasons. Having said that, some people do struggle with some of the rules for a variety of reasons. So we coached the staff to just touch base with the person if they're comfortable, give some on-the-spot support. Oh, the mask goes over the nose, those kinds of things. Oh, the face shield, you need to keep it down. And if that didn't work, then they could reach out to their manager, their leader. And we do have a process where we would then have a meeting and engage discussion. And we have a letter. So we would share that as part of our program. We do have a letter to say we've met. Unfortunately, we're not able to support your DCP coming in right now. Here are some things that might help. And then but it has a time. So, in a couple of weeks, let's reassess. And so we have done that successfully, where a family member of a DCP helped support someone in better understanding the need for the IPAC protocols. And then they've been successfully reintroduced back into the program. And part of that is an appeals process too. So if someone feels like it's unfair, we need to have a process to talk about that.
Thanks, Jennifer. And I think that's so important. So the model that you're demonstrating here of there is give and take, there is an encouragement, there's finding solutions together in this and with the appeals processes as well. So I love seeing all the comments coming in. Please continue to share. I'm going to continue on here. Anne is just commenting the program is highly encouraging to families and caregivers, and one that she hopes will be published and shared broadly. So offering her thanks again. Do you allow anyone else in the home besides designated care partners? And that's coming from Mallory in Saskatchewan.
Okay, so every resident can designate 2 essential caregivers. So depending on the circumstances of the day or the week in the community, or so in Ontario, we have colored public health levels of restrictions. So if restrictions are higher, then that might be limited to 1 designated care partner at a time per resident. Or if we were in a suspected outbreak, then it reduces to 1. And even when we were in an outbreak, and again, for Ontario, an outbreak is 1 positive case. So we were very fortunate not to have any COVID outbreaks that went beyond 1 individual. And so in those circumstances, residents were still able to have 1 DCP. It is easy to tell all of the highlights and the good stories. There are some challenges. Some residents have 4 or 5 children and really good friends and a spouse. And for them to choose 2 designated care partners was really challenging. As we are just past the 1-year mark, we have had people, DCPs and residents saying, how can we rotate our DCPs and what might that look like? And so we're hoping that we don't need to get there, because the safe visiting protocols will change, I hope, as people are vaccinated, but it's on our radar. And I should also say that essential visitors in Ontario are defined as, the best example is for overall well-being or palliation. And so if a resident is deemed palliative, and I'm not a nurse, but the clinical team has a bit of protocol to quickly identify, so that we're giving family members and residents some time to adapt to being palliative and have that chance to speak and say goodbye and do the things they need to do. Those family members are able to come in without going through the DCP training and protocol. So kind of that higher urgency. So those are the 2 levels of visitors that we had coming into the home to the bedside.
Mm-hmm. Thanks, Jennifer. Again, seeing lots of great comments and questions coming in, and certainly encourage a back and forth in the chat as well if you want to be responding to folks that are posing questions here. There's a bit of a follow-up from Mallory that you touched upon, and it was a question I had as well that we also get. But now that vaccines are rolling out, and you talked about the rapid testing that's available, what are you anticipating it may look like in order to be able to welcome back essential care partners?
This is a question we've been talking about a lot in the last couple of weeks, especially as we get closer to having our staff and DCPs getting their 2nd vaccine. So we don't know. We're hoping that we will be able to relax some of the restrictions inside the house, so that right now residents are still in the dining room, sitting with their roommate only, and they're sitting distance. The activation and the activities and events are happening cohorted to home areas. So we're hoping some of that life can become a little more normal. And we're still sorting out what general visits look like. How the friend and neighbor down the road, or the cousin, how can they just stop in? And I don't know what that looks like yet. Early on, I looked to Alberta for outdoor visiting protocols. That's where we were getting some of our information in the spring last year to try to support visiting in a different way. And so I'm hoping that across the nation, we can come up with something that helps make resident life a little more normal.
Thanks, Jennifer. I'm hoping we've got time for 3 more questions. We've only got a few more minutes left. The person who is the lead of the program, was this an add-on to their existing workload? And what are they responsible for doing?
Right. So in our homes, the lead became the resident family services manager. So that's the person that's the lead for recreation and also the move-in process. And it was an add-on. And recreation is my background. And so I'm a bit biased in saying that I think the program department and recreation department had probably the biggest changes and impact in their regular normal work. Activities changed completely, trying to support scheduled visits and coordinating virtual visits and all of that kind of stuff. So we did recruit emergency support workers, which are also called care support assistants, resident support assistants are different titles I've heard. And we added those folks to the recreation team to help support some of that work, so that the RFSM could delegate and share some of that workload.
Now, Mike is asking and noting fear is a common impediment to enable safe family presence. And so I know you spoke a bit about it in your presentation, but maybe just a bit more elaboration on the strategies that you employ to validate and address the concerns that the team members were voicing early on, and specifically wondered about the fear caregivers have with visitors or essential care partners introducing and transmitting COVID.
Sure, and that was a huge discussion and continues to be a discussion. So we try to balance the fear and the worry of the worst case scenario with what is actually happening. So I have to do that for myself even. Oh, the numbers are low in our immediate area. So the worst could happen, but let's balance it with that. And then for us, I really think it was talking about all the layers of strategies that staff are doing to keep residents safe, and showing comparatively that designated care partners are also following those very same layers of strategy, and that each one is just a piece of the puzzle of preventing anything from coming in. And so if the mask isn't worn quite right, there was a rapid test and hand hygiene and a screening at the door. And so just we did a lot of work in comparing and showing that staff weren't transmitting COVID, and they're also going to the grocery store and doing the things they need to do to support their life. And so the designated care partners are doing that too. And then that reminder that they also don't want to be the person that brought in the sickness. And, we all are there to support the residents. And so it was just having those conversations kind of over and over again.
I think it was wonderful how you highlighted sort of reinforcing that message of designated care partners are part of the care team. So in that, equating them with the same kind of protocols that staff were using. So last 30 seconds before we start heading into the summary, but just this final question, can you share the process for determining when there's higher level of urgency near end of life?
And maybe I'll connect with Carol after and we can include something. There's a palliative scale that clinical folks use. And as I said, I'm not a nurse. I'm just around them enough to be dangerous. And so the clinical team did a lot of work in education and work with the medical director to talk about making sure that we're identifying if someone has a change in their condition and that we need to be bringing in their family members sooner rather than when it's too late.
Okay, thank you so much. And many, many thanks that are coming in through the chat box as well, Jennifer. I think we're going to move into our final slides that will show our upcoming huddles. This was fantastic, folks. Really enjoyed the discussion. And Jennifer, just your very thorough and comprehensive approach to this work, and really being able to welcome back essential care partners. So upcoming huddles, the next one is on April 8th. Mrs. Jones, who are your essential care partners? So it really moves us into that identification and designating the essential care partners, and you will see the dates for all of the other ones. And so this does, as we are wrapping up, it is the final thank yous to all. Again, thank you to Jennifer and to our learning team for helping us bring us all together. And thanks to all of you in the audience for this very engaging discussion. So this concludes today's webinar, and have a wonderful rest of your day and rest of the week. Thanks again for joining us, and see you next time.